say good afternoon. Okay, now it's afternoon, so good afternoon, everyone, and thank you so much for coming to our Advocacy panel. And thank you so much to Regional 1 for opening up this facility to us again. Always great to partner with you. In just a minute, I'm going to hand it over to Sheena to kick us off on the panel officially. I do want to remind everyone on December 4th, we'll have our CEO roundtable. So be keeping that in mind and put that on your calendars. It's always a great event. Also, we are closing up our, for MHCE members, we're coming to the end of our nomination process for our board members for 2026. So if that's something that you have an interest in, make sure if you haven't done so already, let us know. An email has been sent out, but if you haven't seen it, just go to mhce.org and there's a contact us. That email comes to me, so I'll reach back out. All right, without any further ado, I will pass it over to you. Thank you.
Hello, everybody. I've gotten the opportunity to speak with some of you, so pleasure to meet you all. My name is Sheena Freeman. I'm the Director of Guest Services here at Regional 1 Health. And I'm going to go ahead and get us started. I want to allow our panelists to go and introduce themselves and just tell us what you want us to know about before we kick off our questions.
Wonderful. So I'm Desiree Rosary. I apologize for my voice. Clint can affirm that it's actually better than it was on Tuesday. I am a physician. I'm a hospital, so I work in the hospital at Regional 1 Hospital as well as the Modern Children's Hospital, taking care of adults and children. I'm also an associate program director for our Med-Peats residencies, responsible for recruiting physicians to come here, train here, and help them hopefully stay here in Memphis. Today I'm here more so in my capacity as a board member of the Memphis Medical Society, giving a voice to our physicians and the patients that we care for to provide them excellent care. I'm a member of our legislative committee, and I work with the Tennessee Medical Association to help promote legislation that helps our legislators see the ways that we can promote the health of our Tennesseans as well as our physicians, and allowing to give them a place to practice safely and allow us to promote the health of those that are in our communities.
Hey everybody, I'm Rob Clark, Vice President, Chief Government Affairs Officer at St. Jude Children's Research Hospital. It's a pleasure to be here with you. I am a reformed hospital administrator and spent about 12 years at my colleague's house over there at Baptist. Wonderful opportunity, and I had the opportunity to go to St. Jude in an operations capacity. When I got to St. Jude, they didn't have a public policy or government affairs team, and about 3 years in, when our CEO turned over, he thought that was an area that St. Jude needed to be involved in, and so he asked me to lead and start that effort. So for the last 20 years at St. Jude, I've been doing this, lead our team that covers federal, state, local public policy. Thank you.
I am Keith Norman, and I'm glad that Rob left Baptist. Because at about the same time that Rob was heading up the work at St. Jude, Baptist discovered that they needed the work, and had Rob not left, they would have probably asked him to do it. But they called me and asked me to head up that department, and I began the work of government relations formally at Baptist. And I also oversee community affairs, where I really try to synthesize the work between the two in a way that policy is informed by the needs of the community, more so than a top-down approach of policy dictating to the community. Glad to be here. And praying over this because this says respect to margarita. So I'm trying to turn tea into margarita.
Awesome. So as you all can hear, we have the right people at this table to have this conversation. So let's go ahead and kick us off. So 2025, let's recap, all right? Tell us about wins you experienced that are important to your organization and our community. So let's start with you, Dr.
So what happens when you sit too close to the moderator?
I know.
I'm the first person to answer the questions. Similar to what Keith mentioned, really hearing from the physicians and those that we represent, what are the things that are important? One of the things that we heard was, how do we promote maternal health? Recognizing that we have abortion law in place, how do we allow there to be an expansion of some of those things that are exclusions as far as being able to protect the health of the mother as well as her future fertility. We were able to pass legislation to expand the diagnoses that were considered as those exceptions, and And we are continuing to work with physicians and legislators to try to improve that legislation to allow not only OBGYNs to practice and take care of mothers, but also to promote the health of the children that they're taking care of. And the second is prior authorizations. Unfortunately, you are probably familiar, or someone close to you is familiar with the term prior authorizations. That is where a physician says that this is a required treatment or medication, and an insurance company says pause. We must first get additional information from you, and we will let you know if we think that this is appropriate for you. And so we have worked to try to minimize the administrative burden for our physicians, because when we are notified that a prior authorization has to be confirmed, guess what happens? Your doctor tells you that there is a prior authorization that has to happen. It seems unnecessary for us to then re-inform you if the insurance company says, hey, we need more information. But that's what the law in 2022 said. Every time the insurance company asks us for additional information, we then had to notify you. That's additional administrative burden. We were able to remove that from the legislation, which is amazing and wonderful. So we have more time to talk to our patients. The next was vaccines. As a pediatrician, this is something that's near and dear to me. Why? Because when my patients are coming in, I see what happens for those that are immunized and those that are under-immunized. And how do we continue to allow physicians to have the ability to provide vaccinations for those that are interested, while still protecting the autonomy of those that come to see us. In particular, there was the Forgo Medical Treatment Act that was actually able to be held. And essentially this said that individuals were able to refuse treatment or refuse being kind of detained if they had a communicable disease. The way I think about this as someone who practices here in Memphis, Tennessee, is tuberculosis. This is a disease that is endemic in our community, is not common in many other communities. When a patient is diagnosed with active tuberculosis, they are told to come to the hospital. They stay at the hospital until they are no longer able to communicate that disease. Why? Because it is highly communicable. Having that legislation in place would have prevented us from doing that. And so we've been able to kind of allow our physicians to create a healthy environment, not only to take care of patients, but also for those in our community to continue to do the things that they enjoy and love. And so those are some of our wins.
I would say for 2025, our biggest win is we've survived so far. We're here, and I say that, I always use this opportunity to do a level set about some things that make St. Jude unique and makes our policy interest unique. So St. Jude is a children's hospital, yes, but we're not a full-service children's hospital. We don't have an emergency department. You're not going to come to St. Jude to fix your child's broken leg. Our mission is to do research and treatment on pediatric catastrophic diseases. So really the essence of what St. Jude is all about is scientific discovery and rapidly translating those science discoveries at the bench through clinical trials to the patient's bedside. And so I would say most of our focus in 2025 has been at the federal level because there have been a lot of biomedical research related things that have come down from the Trump administration. And we all knew that when President Trump was reelected for a second term, what we were going to get. Now, during his first election in 2016, I think there was a lot of uncertainty, and I think, honestly, he and his administration were uncertain about what their goals were, and he was a true newcomer to Washington. In 2021, he was not a newcomer to Washington. He knew exactly what he wanted to get done. I'm sorry, 2025. What he wanted to do, and he has put the people in place that are very familiar with how to move the levers of government. So from day one of his administration, we've been reacting to executive orders, many of which, like I said, have impacted biomedical research, including attempts to cap the indirect expense rate on NIH grants at 15%, which would be a huge hit to academic research institutions like St. Jude. Now, it hasn't all been negative, and we're going to talk about some specifics from the One Big Beautiful bill, I think, later today. An example of a very positive thing that we saw just last week, because again, our issues include the therapeutic pipeline that FDA controls for approving therapeutics for rare and ultra-rare pediatric diseases. And just last week in a New England Journal of Medicine opinion piece, the FDA director came out and said, we as the FDA are taking too long to approve some of these novel therapeutics. The number of patients on clinical trials are too small. We can't rely on data from randomized clinical trials like is what the gold standard for most clinical trials are. This is something that we at St. Jude and other academic research centers that deal with rare diseases have been saying for years. And now we're hearing the types of things that are very appealing to us in terms of compressing the timeline from 10 years to maybe 18 months, which would be a huge game changer. So I'll stop with that, but I would say, you know, the thing that our team on the policy side has really had to pivot this year is to rapidly digesting and translating the executive orders for our leadership so that they know how to respond and how this fits in with our strategic plan.
I would echo everything that the panelists have already said, and not to be redundant, but definitely this last point that Rob made, which is how to unravel some of the executive orders in a short time frame, and then how to ramp up from a bill that we'll talk about in a moment that we had no details for until the 11th hour. Specifically in Tennessee, though, the Hospital Investment Program, HIP program, it was very helpful for healthcare systems all across the state of Tennessee. And so that was extremely important. We had similar legislation, and I often refer to this when I'm working in rooms like this, because I work across 3 states. In Mississippi, we had similar opportunity there to receive funds that reinvested in healthcare systems and hospitals equitably for the services they provided. And that was good for us. It was something that we had worked on for quite some time, so the hospital investment program is excellent. We did work also on HB1, the visas, prior to what's about to happen now, because there was already some impact taking place on getting workers. We recognized there was nursing shortages and there were medical professional shortages all around. And so we started that work early, only to realize here now that it's about to be impacted again with the increase of cost, what it's going to cost for a worker to come into the country and how that will be impacted. Another thing was the CAA bill. If you recall that the certified anesthesiologist or anesthetist in this state, that was a designation that we recognized due to some of the shortages that were in the atmosphere and the way, I want to say private equity or large organizations have come in and said, look, we're going to buy these services and group these services at contractual cost. We talked about this last year in this setting, how they go up incrementally each year, whether or not the services increase or so forth, up 6 to 10, even 15%. One of our healthcare systems in this community experienced a terrible setback because they did not have anesthesiologists available to them at a certain period of time to perform services. And so having that stopgap measure and that bill to pass was a great win for healthcare, not just for us, but we like to think of it in terms of, I'd like to think of it in terms of a win for all of us.
So as you all can hear, they have been very busy this particular year. So
That was January.
That's right. So as many of you have already kind of spoken about are the HR1 or the One Big Beautiful Bill. So my question is, for better or worse, has disrupted the Big Beautiful Bill Act, for better or worse, has disrupted the healthcare industry. Excuse me. How is it or will it impact your organization or industry? And Keith, we'll start with you, Dr. Hunt, we'll start with you.
Yeah, the problem with sitting too close to the moderator is you get to start first and then all the answers are exhausted. And then sitting on the opposite end of the moderator, you know the next question is coming to you. So, Big Beautiful Bill, for better or for worse, I'm gonna be saying those words. My son's getting married tomorrow. So I'm gonna be saying those words again in 24 hours. But it's been a challenge for many of us, first of all, grabbing it just to put our arms around it. The thing that's going to concern us the most, let's talk about where we are. Shelby County, Memphis, Tennessee, poverty, declining population. 680,000 people across Tennessee in December will be impacted by this bill that will remove subsidies from ACA. And it's going to increase uncompensated care across the spectrum. Everybody's going to suffer from that. Uncompensated care is never a good thing. But then when you drill down to it and you look at West Tennessee, 167,000 people in the West Tennessee region, largely consolidated into the Shelby County arena. Okay, let's talk about that. And while we keep, looking at all of these numbers, and we'll get into this question again, a part of Big Beautiful Bill was money for rural health in those areas. But don't be fooled by the number. The amount of money that's going to be available from this bill sounds great when you say it in one open conversation, but when you divide it by 50, and then when you look at Tennessee and you say, by definition, there are at least 76 hospitals across Tennessee that fit the definition of rural hospital, and then you say, now go fight for that money. And I've recently learned that it's not just us that's competing for this money, hospitals and healthcare providers. You got education systems that are competing for this money. I just learned, and there's a fact check on this, Dollar General is competing for this money. So, think about that you have big box providers who are saying, come here and get your nutritional health information at Dollar General. And then as soon as you get your pamphlet on how to get prenatal care, go right over there and get some Little Debbie snack cakes and some boxed macaroni and cheese, right? To contribute to that. It's just it sounds huge and it sounds great, but we have a lot of work to do in this space because it boils down to people's health and it boils down to the quality of life for individuals who we need to provide care for. So Big Beautiful Bill still has a lot that's going to play out. I'm hopeful that there will be at least a staggered scale on the subsidies going away, not all at once. Because all at once, we're talking about over 20 million people across the United States, upwards of 22 million by some estimates of the Kaiser Foundation. So it can really be a tough hit against healthcare. And then about 380,000 jobs in healthcare will go away as a result of this as well.
Yeah, let me piggyback on what Keith said about the Rural Health Transformation Grant. One of and again, for St. Jude, we don't anticipate there's going to be a whole lot in there that would benefit us. Potentially, that there may be some things in terms of public health. We have an HPV cancer prevention program that's very robust at St. Jude, and so pushing to eliminate that through the uptake of that vaccine could potentially be a benefit to us. But one thing that the governor has stated in his proposal to the CMS is they want to eliminate certificate of need in the state of Tennessee, and that has a huge impact for hospitals and for physician practices that are looking to expand by building new capital. Of course, certificate of need has been around for decades as a health planning tool. As we've moved forward over the last several decades, a lot of more conservative-leaning states have totally done away with certificate of need, stating that it really inhibits the free marketplace. In Tennessee, I know the Tennessee Hospital Association has worked very hard to preserve some elements of certificate of need, and so this will be a big issue next year for the Hospital Association. And again, that all stems back from HR 1. Some other things that I think there's some positives and negatives that we've seen from St. Jude. A positive is a rule easing Medicaid and the Children's Health Insurance Program enrollment. Obviously, every child having access to care, whether it's at St. Jude or Levana or any other children's health provider, is something that's important to us. A negative is that the bill pushed the burden onto states, and we're afraid that now states are pushing the burden down to providers in terms of verifying addresses. Again, this comes back to citizenship, immigration, really big hot button issues And, you know, we're certainly, we want to be able to abide by the law, but we feel like the burden should really be at the state level in terms of verifying citizenship and not at the provider level. So that's something that we'll be continuing to work on. And then I would say one other thing, and I'll stop. One thing that the administration wanted to be included in HR 1 but was pulled was they wanted to put a moratorium on states for passing any artificial intelligence laws. So that was pulled out. We saw that as a positive because we don't anticipate that the federal government is going to be able to come up with a cohesive AI policy anytime soon, and yet there are some very real, you know, impacts to patients that are around AI that we feel like the states should have the opportunity to pass legislation for. So I said that's a positive. They pulled it. The administration has telescoped that even as early as tomorrow, they're going to issue an executive order that would place a moratorium on states to pass new AI legislation. So again, these are all things that are continuing to come out. And because the president likes to use executive orders, which does not require Congress to pass legislation, they're able to come out with these things very rapidly, and so we have to be able to respond to them rapidly.
So just to provide another lens of kind of looking at it from the physician aspect, and talking similarly as someone who works in West Tennessee, and I'm trying to advocate for our patients and those that work here, is the patients that we care for that are on Medicaid, and the number of patients that are currently on Medicaid, and the number that will not have Medicaid based on the big beautiful bill and the work requirements and the other restrictions, having them reapply every 6 months to be able to be on Medicaid, having to submit paperwork. Physicians have trouble with administrative burden. I can't imagine patients now having similar things that they have to navigate. And we know that our physicians have a heart for caring for these patients, but we also recognize that the reimbursement for Medicaid patients is already low. Something we'll talk about in a future question are some of the things that we're trying to advocate for to increase the reimbursement for our TennCare patients. Not because physicians need more money, but because if you're being paid 50% less of what Medicaid costs across the country, you can't keep your doors open. You can't care for these populations, and they're already vulnerable. And there are already limited numbers of physicians that are able to see these patients that are currently on Medicaid. So one of the things from our perspective that I feel like we are most concerned about is the number of patients that will now be without health care. And even looking at it from someone who works in the hospital, patients come in, I take care of them. I don't care if you have health insurance. You come in, I take care of you. That's what I do. But I recognize that the hospital needs money in order to work. So there's someone that comes around, if they're not enrolled in Medicaid and they're eligible, they enroll them in Medicaid. And what currently exists is they can then be retroactively paid for any care that is provided so that we can focus on just providing care. Currently, it's 3 months if you're within the Medicaid expansion and 2 months if you're within certain special groups. That's going to be further decreased. So that's going to place additional burden on hospitals that are already straining to provide for these patients and to be able to allow us to take care of them. And we'll probably talk some about hospitals, rural hospitals that are closing. How do we continue to allow hospitals to be viable in healthcare facilities as well as clinics and other places that physicians work?
And since all of you have already kind of alluded to the rural conversation, rural community health conversation, let's go ahead and go there. So both federal and state lawmakers are, as you all talked about, prioritizing services for the rural communities. While Memphis is not a rural area, we know that. We all know that much care for rural residents in our region is delivered to Metro Memphis. So how is your organization planning for this, and will you take steps to further educate lawmakers about this issue? So I'm gonna go with Mr. Clark on this one.
Yeah, and again, I'll have a very short response to this because, you know, rural care is not, you know, a big part of St. Jude's mission. I would say that outside of Memphis, we do have several clinics in other states, some of which are more rural. Springfield, Missouri, we have a clinic affiliated with the local children's hospital there. And so we do follow policies in all 50 states because we take patients from all 50 states. And so we have to be abreast of issues that could impact us even here in Memphis, even though they're in other states. So I would say that, you know, for St. Jude, we're supportive of our colleagues in the greater Memphis healthcare community in terms of increasing access to care for their patients.
Can we get a letter of support that states?
So we have a Doctor's Day on the Hill in March. We have a chance to go to the state legislators' capitol. You wear our white coats. When you wear your white coat, you look really fancy and people listen to you a little bit more. I didn't wear mine today, so I hope I'm not losing that effect on you guys. But those are our opportunities to talk to our legislators about things that are important to us, including the Rural Health Transformation Fund. So not only talking about how do we expand healthcare in these rural settings, how do we support our hospitals, our physicians that are there, but how do we also expand such that we have individuals that train in these rural communities that are actually there, learn the people that are there, and decide to stay there. I would say that there is some synergy because University of Tennessee Health Science Center is partially funded by the state to figure out ways to how do we increase the number of people that train here in Tennessee so that they see how amazing it is, and then get them to go out into these rural communities, whether it's on rotations or other activities that they do, to actually experience what is it like to be in those communities. I will acknowledge, as someone who has been through medical school and has a small house that I will never live in, that I owe a lot of money to, that may not have been paid on recently, but here we are. It's okay. You get a lot of debt at the end of 4 years, and then you work for 3 to 6 more years, making less than minimum wage and working more than 80 hours, less than 80 hours a week. We'll say less than 80 hours a week. So that's actually what we're working. And so it's alluring to work somewhere where you feel like you're going to be paid a lot of money or in a setting that has lots of shiny things. So how do we demonstrate the value of working in these communities so that they can understand that there's more to medicine than just necessarily working in the quote-unquote emerald city?
So I have the long answer on this one because Baptist provides so much health care in rural areas in the state of Arkansas, in Tennessee, and in Mississippi. And so many of our outposts, many people see the large hospitals that we operate, but we have over 25 hospitals in our system, of which about 20 of them, or 17 exactly, would qualify as rural. But I want to open that up just a little bit more, that the idea of rural health can be a slippery slope when it comes to this particular bill, because all of the people who can compete for the dollars are not necessarily in rural spaces. Because this bill opens up opportunities for mental health, it opens up opportunities for technology, it opens up opportunities for services. The individuals who are competing for the dollars may not be providing actual care in the rural space. They may be connected to, or they may provide a vendor-based service to a particular hospital, and that money comes out of this bucket of money. And so when you read through that 900+ page document, you'll see that there's some real fine nuances in there that you have to pay close attention to. So as far as rural health in the Memphis area, we see an opportunity to provide services, at least by way of the technology portion of the 3 states that we operate in. All of them have listed technology as a priority. So that would at least give us the opportunity to have neurologists by way of telehealth, telemedicine, in spaces where a neurologist would not normally exist in Tipton County, maybe in other smaller areas around Tennessee and in Mississippi. So that would be a blessing for us. The big piece of it, though, is going to be in the area of maternal health, pediatrics, and we don't have enough OBGYNs in some of the spaces and services in the counties across the Mid-South. We see that Tennessee, Arkansas, and Mississippi are somewhere between 46 and 50 on every list of that being a challenge when it comes to maternal health. And so that has to be at least the #2 priority in the rural health transformation monies across all 3 states. And with that being said, the question then becomes, how do you provide the care in those counties that don't have road reform? You could have a crisis at a birthing center that you must be within 30 minutes or less of a hospital that could provide the service for a mother who is in labor and experiencing trauma or difficulty. And so there could be so many other things, ambulance services, and all of the real complicated things that you have to think through. So in this rural health transformation packet, there's a lot more to be considered. And again, you put the big number out there, but remember, this money is not forever. This is 2 tranches of released dollars, 50%, and then based on performance, the other 50% comes forward. And then you begin to sustain it on your own, because one of the things that is explicitly written in the grant or in the program, in the bill, is that these need to be sustainable solutions that are being presented. So once the dollars are put forth, the hospital system or the healthcare provider needs to figure out, is this sustainable and can we keep going? No dollars for new spaces, dollars for possible machinery that you might need or heavy equipment that you might need, but nothing for build out or anything to that effect. So there's still a lot of challenges in there. I think it's a good thing that many of the people who were trying to put something in the bill said, wait a minute, if you take away the ACA subsidies and you start the reimbursement, lower the reimbursement from CMS, then you're going to sink rural hospitals, of which we've seen 19 across the state of Tennessee close over the last few years. Texas was the only place that had more to close than we did, and that's because they got more hospitals. But we were second on the list at some point. So all of those challenges still exist. While it is a great opportunity, I think this is where healthcare systems and providers of all walks of life in this room could really come together and say, here's a legislative agenda that we feel like we really need to work towards together to solve some of the problems in our region.
Thank you so much. I appreciate you all talking to us about some of the federal things going on. So let's shift gears a little bit. Let's kind of talk about our state and local government issues. What issues are you all monitoring, and how are you planning to run that legislation of any issues? Let's start with you guys.
Wonderful. So Rob kind of alluded to this, which is the presence of AI, which is everywhere now. And what does that look like in healthcare? We were excited about the pullback from a federal mandate as far as AI integration into healthcare, and we feel like that should actually rest at the state level. And we think that there should be physician oversight as far as how AI is integrated into healthcare. We acknowledge that AI isn't going anywhere, and it is a useful tool. However, it will not replace a physician being able to come up with a diagnosis. And we recognize that AI is not foolproof because a human made it. Therefore, it can come up with an inaccurate diagnosis. So there has to be some level of oversight in however we use AI, and it should not be autonomous. We recognize that it has a role. Maybe it's reviewing imaging and identifying maybe some common patterns in how a disease maybe presents itself. Or even helping us expand our differential diagnosis. As a doctor, my job when I see a patient is to have a list of possible things that they could possibly have. And then when I exhaust that list, I have to go back to the whiteboard and try to make that list even longer. And AI has the potential to allow me to have that more exhaustive list when I first see a patient. However, it's not going to tell me what the actual diagnosis is. So that's one of the things that we're very excited about. And then the next is kind of TennCare payment reform. Recognizing that in order for us to allow physicians to continue to take care of this population, we have to be able to provide them with reimbursement to keep the lights on, to be able to pay their staff, and to be able to function in those spaces where resources may be limited. There are new monies that are going to be available within the state because of other legislation that is ongoing, so we think we have a payment source, which is always great when you have an idea for something that you want to be paid for and to increase the payment of, if you can show them where the money is. So we're hopeful that that will be something that we can talk about when we go to Capitol Hill. And then the other is kind of insurance payment reform. We really want the physician and the provider to be able to focus on their patient interaction. You should be able to provide care and not worry if the insurance company is going to come back 3 months later and say, actually, we don't want to pay you for that. So we're going to take that money back and sorry. And it's something that is happening. And what we're asking for is for transparency and clarity and why those instances are occurring where they are choosing to take back money or to say they no longer want to pay for a service, so that it's consistent, it's equitable, and physicians can understand what it is that they're navigating and how best to provide care for their patients.
I would say from the state and local level, I can't talk about all of it because my competitors are in the room. But we have to have a real serious conversation locally about prioritization of dollars. Healthcare touches almost everything. So when you think about what we're talking about in Shelby County, you saw the headlines, $43 million of shortfall just to pay the workers. $1 billion, $2 billion for a jail. A couple million for doors, right? Then we need our trauma center built out, and we really need our trauma center to exist in this community, not just for having another hospital. Think of it as a business tool, because you're not going to attract major conventions to your newly owned hotel that you have to refurbish and renovate for $237 million if you don't have a trauma center, because you don't want to go to a city at a major convention where there's someone who could get sick or something could happen, and there's not one. So that's a part of it, and many people don't look at that tie that even the Memphis Convention and Visitors Bureau has spoken of. You gotta have it. And so where the dollars are gonna come from and how we're going to appropriate them. Local doesn't impact healthcare as much as state. So in the state rounding of dollars, we're hopeful for a couple of things. The hospital investment program is a great drop, but remember CMS at the same time introduced the level setting of the funding of 118% of the poverty level, and that's going to level out by 2028. And so while one number came in, other numbers began to fall down. And so if we can impact that before it comes to the level set, so that we can continue to get an increased amount of match on the dollars, we're going to be far more successful. We've got to have help from our state government, and the priorities need to be for hospitals and not for other things. And that's extremely important for this particular region. In other areas of our state, the healthcare systems seem to prioritize those things, and they work together a little bit more. I would suggest that may be something that we have to think about in this part of the state as well, to work together to get those dollars in the area and spread across the region, more so than just having them for ourselves.
Yeah, so in 2025, there were a couple of science research-based bills that passed in Tennessee. One of them we liked, one of them we're not very fond of, and we'll look to try to amend in 2026. The one that we liked that was passed is the Individualized Investigational Treatment Act, which is codified as Public Chapter 45, and it actually went into effect July of this year. And that gives patients the right to try expanded therapies like antisense oligonucleotides, neoantigen vaccines. Again, we're supportive of anything that gives patients the right to try new therapies, as long as they consent to that and they review the risk and rewards. Some legislation that was passed that will go into effect January 1 is the Tennessee Genome Security Act. Now, this is a bill that's well-intentioned, and basically the intent of the bill is to prevent any harvested organs to be used in a way that would benefit a country like China or Iran, one of these bad actor countries. The likelihood of that ever happening, I think, is very rare, but again, to follow the intention of the bill sponsors, that's what they wanted to do. The problem with constructing some of these well-intentioned, very narrow issue bills is that a lot of times they're written so vaguely that other negative things, unintended consequences can occur. And in this case, the language is written so that if you utilize genome sequencing equipment like St. Jude does, there cannot be a component part of that gene sequencing machine that was manufactured in a country on a certain list. Well, it's almost impossible to tell if a certain component was used in an Illumina gene sequencing machine. So we will be working with Vanderbilt and UT and other academic centers across the state to try to amend, again, just narrow down that language so that it doesn't have the unintended consequences that we're afraid it does. One of the things that we kept an eye on in 2025 were some efforts to kind of roll back the 340B drug discount program, which would be very harmful to everybody at this table and a lot of providers in this room. 340B is a federal program that that is intended to assist safety net hospitals like Regional 1, Baptist Methodist. When they take care of patients, they can offer certain medications at a discount. Very beneficial to, again, patients accessing these needed medications. The program has since been expanded to also include children's hospitals and cancer centers, both of which St. Jude checks those boxes. So we benefit from 340B. Most of our pharmacy is outpatient based because most of our patients are treated on an outpatient basis. And so we save a significant amount of money each year. 340B is something that the pharmaceutical industry has never liked. They keep trying to fight that at both the federal and at the state level, so we have to continually keep that on our radar, and we will for 2026.
We have roughly about 10 minutes left, so I want to make sure we allow time for you all to ask questions as well. So next 2 questions, we're going to kind of keep them brief if possible. So we've talked a lot about, you know, what your organizations have going on both federally and at the state level. But just tell us what other issues your organizations are tracking the remainder of this year and going into 2026. You start with you, Dr.
Okay, so I would definitely say we still have 340B on the radar. Site neutral payments for us are something that we want to keep an eye on. That's just making sure that we don't get caught up in a network of having what we call this equal pay for equal procedure, but the procedure, if it doesn't go well in one space, becomes my patient at the hospital. So that's a big thing that we have to look at. The CON reform piece in Tennessee, we're saying pump the brakes and slow down, because in the bill that was written and turned in, the plan that was turned in by Tennessee, one of the second or third items on the list is go ahead and get rid of CON. CON is already on the chopping block. It's being pared away little by little, year by year. So we definitely are keeping an eye on that. We were successful in getting some things passed in Mississippi and in Tennessee where we could purchase items and not have to get a CON for purchasing of those items, which has been helpful. So those are things that we're continuing to just monitor and watch.
Yeah, I think at the issues that we're really focused on are again at the federal level. The first is just the federal investment in biomedical research. The United States has been a leader in biomedical research that benefits patients. It's an economic driver for so many communities in this country, and Congress has been supportive of this through Democrat, Republican administrations. Congress has been the reason, because it's been a bipartisan issue, that we've been able to significantly fund biomedical research in this country. I think, you know, there are proposals from the administration that would significantly cut into the funding, which would also mean that the United States would probably lose our leadership. And I don't think we want to cede leadership in this important area to China or to India or to any other country. There's so many good benefits to that, and so we're going to be fighting very hard in 2026, working with Congress. Hopefully this is still a strong bipartisan issue for them. And something that ties into that is workforce. And there's some immigration policies that have been proposed. One that would significantly cut into the use of H-1B visa waivers. These are waivers of highly technical scientists and healthcare providers that come from other countries that have unique skills, and they stay here for a certain amount of time, and then they go back to their home countries. It's benefited healthcare providers and systems across the country, and there's a proposal on the table that would assess a fee of $100,000 for each new H-1B visa application. That would be very detrimental to healthcare and the research enterprise, not only in Memphis, but across the state, across the country. So again, we're working with other independent research institutions and healthcare systems across the country to really raise awareness about those 2 issues.
I'll limit myself to one issue because I'm about to have a coughing fit. My voice is slowly dying on me. So that issue is scope of practice. Thank you, kind sir, kind sir. We recognize that there is a healthcare team, and that healthcare team works well if everyone is able to function in the role that they were best trained for. I work well with my advanced practice providers, my bedside nurses, the technician, the MAs, all of those people that comprise the healthcare team that allows me to take care of a patient. And so we recognize that there is a need in Tennessee. We have areas that are underserved, that are rural, that do not have as many physicians. But we want to make sure that we invest in ways that allow us to maximize that healthcare model so that those that are practicing are appropriately supported. And we recognize the fact that advanced practice providers are able to step into those spaces and help be that extension of the physician. But it's important for there to be oversight and for there to be someone that they can talk to if they run into something that they're unfamiliar with. In residency, that is what we are doing. We are in an environment where we're essentially apprenticing, and we are taking care of patients. There is someone that is there to provide oversight to ensure that that patient isn't harmed as we're doing that. We want to ensure that the model that we have here in Tennessee allows the physician to continue to be that individual that can help guide the advanced practice providers, whether it's a nurse practitioner, a physician assistant, as well as the other members of the healthcare team to care for patients.
So in closing, the final question, as a time when civil public discourse, like it seems to be the exception rather than the rule, what is your advice to many of the people in this room who may not live and breathe healthcare? What could you do in terms of what can they do every day from an advocacy standpoint to make sure that those largest differences and those issues are being able to be addressed? What can they do? We'll start with you, Mr. Clark.
All right. This is so important, I think, and it's a message I try to convey. I talked to, I know we have an MHCE student from the University of Memphis here. I talk to their year one class every year, and always say the same thing in closing, is that each of us are very important members of our community based on the work that we do. And so we have opportunities to lead in advocacy, whether we have government affairs by our title or not. We all, I think, have the role and the duty to advocate on policies that are going to benefit patients in this community. And I think we do that by getting engaged, by going up to Nashville when you have the opportunities with Days on the Hill, or don't even wait for that. I mean, just take a day and go up and make appointments and meet with your elected officials in your district, in both your home district and your hospital or your medical practice district. And that goes so far in terms of the legislator's perception of you as, again, a community leader. They say, wow, this person has taken the time to come up here and express, his or her opinion to me. And so that sticks with them. I know it doesn't seem a lot of times like it does, and it can. Listen, this is a long lead time game that we're in. You can't expect to have immediate wins all the time, but slowly over time, if you are consistent in your message, it does pay dividends.
I would agree with what Rob said. We're fortunate to have Dr. Woodbury, who is a dermatologist, and we call him the coffee doctor. So he actually meets with our local legislators and has coffee with them. So we meet with them one-on-one, not when we're asking because we need something, but just to start to establish those relationships. And that has been infinitely helpful. Why? Because they get to know him as an individual. He gets to bring up things that are concerning what we're seeing, or even hear from the legislators questions that they have for us that they don't know the answer to, that they're genuinely wanting additional information. I would agree that they really want to hear the voice of the people that they are representing. And I would say the most impactful things that I see at Day on the Hill, or when we have our legislative meetings, is when someone is able to give voice to an experience that they had. Because that suddenly paints a picture of how that legislation is impacting an individual person in their day-to-day life and what the consequences are. Because we are all a part of that community. And I think that those are the stories and those are the opportunities, if you have them, that are the most impactful, and that will allow you to kind of help move that needle and help us make the change that we know is important for our community.
I'm going to give it the same spin and add two more things to it. Your presence obviously means everything. And I will say that the practitioner's presence means a little bit more than mine and Rob's, because we are there and we are administrative. But when a doctor shows up, or when someone who is hands-on with the patient, whether it be in an individual basis or group, they really do lean in and listen. I have a group that I take with me on a regular basis. I'll tell them when I really need them to be at the table, And when they are there, it seems as though the questions become very intense, and they get in there and they do the work. If you have a local political action committee, a PAC, could make a contribution to it, because it goes a long way when we're able to support the organizations that support our legislators, the ones who especially go out and champion issues for us, and then when we're able to do it. Show up at some of the legislative events and dinners. I mean, when they're having them, you know, you are a person who's welcomed in your client, your constituent, and you go into that room and your presence means a lot. Doesn't mean you gotta vote for them, just means you want to influence the outcome of the issues. And show up ahead of schedule rather than the day before the vote. That's a big difference. And Rob kind of leaned into that just a little bit, but when you're there a few months or regularly or once every now and then, that's good. When you show up the day before a vote, pretty much the decision's almost made. And so all of those things are helpful, and to just really be concerned with health care overall for the people that are in our communities.
So we are going to open it up for any questions, any pressing questions that anybody would like to ask. Feel free to raise your hand. Okay, go ahead.
I have a question. This is around hiring. I know you were talking about difficulties with visas, but I've been hearing a lot of hubbub about the Department of Education de-designating nurses as professionals. Are you hearing much about that at your level and the effects that it could have on nurses? Because it would take away their capability for student loans?
So are you talking, would this be taking away their licensure status, or?
They were de-designating it as a professional status. It started out, I was hearing it about public health professionals. Could you speak to that any more than I could? This is social media. I've been hearing about this through an epidemiologist.
Yeah, that's not something.
Yep, you all haven't heard
that I've
anything much
heard
about that yet.
The only educational impact that I've heard about that's factual is the cap on loans, the amount that healthcare
Right.
professionals and doctors or those in medical school can borrow.
Well, this is more around the designation as a certified professional and its effects on your ability to get student loans for those programs,
Yeah.
that they're not considered professional programs. But this has just happened like in the last 3 days
Oh,
that I was.
well, you stomped the panel.
So actually, the dean brought this to, I'm at the University of Memphis School of Public Health. The dean brought this to our attention last Friday or Thursday, public health institutions across the country, this designation is being removed, which means that those individuals coming through those institutions will not qualify for the financial resources.
Is this from a federal standpoint?
It's from a federal standpoint.
We're talking about Federal Department of Education.
Yes.
Right.
Federal
And then
loans, okay.
nursing came on afterwards.
Definitely take a look into that.
Yeah.
Their
Writing
added,
it down.
I saw speech language pathology has now been
Physical
added as
therapy.
well.
Yeah.
So, and this is really
A lot of the
just in
allied
the last
healthcare.
several days that
Yeah.
this has happened.
Look into it. Thank you.
Thank you for bringing that up.
Yeah.
Any other questions? Yes, sir, in the back.
Y'all knew I was gonna have to ask one, right?
Can you speak up a little?
Yeah, Clint Cummins from Memphis Medical Society. I think almost every institution in this room was represented at a dinner with Brent Taylor a couple of weeks ago. Congratulations and condolences for those that were there. But something that came up, and Keith, you touched on this as well. When we go advocate or educate our elected officials, and when I say we, I'm saying groups that represent providers, groups that represent hospitals, and probably groups that represent academic institutions, we almost never come with the same message. On the usual other side, of us, the insurance companies always come with a unified message. And Keith, you were talking about this earlier, and I think that's the fundamental question, is how do we get more organized? I mean, you were talking very broadly from a community perspective. You're throwing in tourism and things like that, as you should, but I mean, even more narrowly from a healthcare standpoint, how do we actually accomplish that? Because Dr. Burrows-Ray brings up scope of practice. Physicians say one thing, nurses say another, hospitals may say something else, academic institutions may say something else, and we haven't even named all the healthcare professions and everyone's different opinion. So anyway, long-winded question, but I think fundamentally, how do we coordinate more as healthcare groups in West Tennessee?
Well, I think this forum is obviously one of the best because it brings together professionals from across various disciplines, but allowing the needs of the patient to dictate the agenda. Oftentimes, if we're honest with ourselves, the mission ought to be healthcare and providing excellent healthcare. And we need to look at it from the perspective of the various reasons why we got into the work. I benefit nothing from my fellow institutions suffering. And I benefit nothing, because I can only provide so much of the healthcare in this particular space. And so I think we have to sit down and determine what are the things we can work together on and outline those things and come forth with an agenda that we can agree on. Legislative priorities, many people do it. And our industry is not different from any other. We have a county government and a city government, and trust me, if you read their legislative agendas, you'll think you live in two different places because they are not the same. The priorities 1 through 10, and you go, am I living in the same community? And then I live in the city and the county, and it just doesn't add up. And so I think those are the kinds of things we can do together. We won't agree on 100%, but I'm sure we can find several, I'll mention that's 1 or 2 maybe, that we can agree on and put those forward and put energy behind.
Any final question before I turn it back over?
Just wanted to close us out and express our gratitude to our panel. We are very honored that you take time out of your day to be here. Likewise to the rest of you, we are so grateful for you being able to come and join us today. There were many, many other things that you could be doing right now, and we're just grateful that you chose to spend this time with us. I spoke specifically to those of you who are members of MHCE. Grateful you're here. MGMA, always so great to be able to partner with you for these events. I'm just so thankful that we've got a community where we can work together, especially so many of our areas overlap, so thank you. One request I have, to help us improve future discussions, to improve the education that we can provide, just a few minutes ago, an email was sent to you with a link to a survey. It takes about 3 to 4 minutes to complete that survey. Additionally, if you want to, at the very back of the room, there's a laptop with a QR code, and I can vouch for it. The QR code is valid. It's not some phishing scam. But if you want to do that instead, just take a snap of the QR code, take the time to fill that out and help us to improve it. And to sweeten the pot, we got cookies in the back too. So once again, our next meeting is December 4th. It is our annual CEO Roundtable. I look forward to seeing each and every one of you there. And please, once again, just let us know through the survey what we can do to improve these type of meetings. Thank you all.